No, it's not projecting. Sorry. Give me a second. Some technical issue.
We can see
Oh, you can see. Okay.
slides.
So I'd like to start right away. I'll introduce the panelists. Dr. Prem, if each of you could just say hello that you're there. Dr. Prem is a geriatrician in Mumbai. I'm so sorry, I missed you. Hi. Dr. Anant Ramaswamy, he's a medical oncologist and runs the Geriatric Oncology Clinic at Tata. Anant, hi. Dr. Joyita Banerjee is a geriatrician from Delhi. I think she had a family emergency and she had to leave. Are you there, Dr. Joyita? Or maybe not. And Dr. Joyita Devdar is our psychiatrist who takes care of all of our older patients with cancer at Tata Memorial in Mumbai. Dr. Joyita, are you there?
Hello, hi. Good afternoon.
Good afternoon. Ms. Jyoti Krishnamurthy is a gerontologist and our social worker volunteer in our geriatric oncology clinic at Tata. Jyoti, are you there?
Yeah, yes, ma'am.
Hi.
Hello, everyone.
Hi. Dr. Sridhar Sundaram is a gastroenterologist and in the Department of Nutrition who takes care of our nutritionally vulnerable older patients with cancer. Dr. Sridhar, are you there?
Hi.
Dr. Sarika Mahajan is our physiotherapist, a very active physiotherapist, and there's an entire assessment of all of our patients and a follow-up. Dr. Sarika?
Hi, ma'am. I'm here.
Hi. And Dr. Vikram Gota, our clinical pharmacologist and one of the most avid supporters of our geriatric oncology clinic, and he sends his students, and some of them are here. So, Dr. Vikram, are you there? You're here in person, sorry. Hi. The last three need no introduction. We have already heard the excellent talk. So Dr. Kaneswaran from Singapore, Dr. Soto from Mexico, and Dr. Steer from Australia. So let's start right away. So this is a real patient that we saw in our geriatric oncology clinic, and several of these issues I really don't know how to solve. So let's start. So she's a 77-year-old woman, lives in Mumbai. She's a widow but lives at home with family. There are 3 people who live with her at home. She comes to our clinic with her granddaughter, who is one of her primary caregivers. So we were lucky. This is a person from Mumbai. Oftentimes, a large proportion of our patients come from outside Mumbai, and they are not accompanied by their primary caregiver. But in this case, she was. She is illiterate. She was a housewife. She is well preserved. She had an ECOG of 1 and exercise tolerance of 2 floors. Never smoker, no addictions, no family history. She had a history of cecal cancer 3 years ago in August 2018. Underwent a right hemicolectomy and 8 cycles of adjuvant capecitabine completed in December 2018. She has some comorbidities. She's hypertensive. She has diabetes for the last 10 years. She's on hydrochlorothiazide, glimepiride, and aspirin. She's also taking a multivitamin, calcium and vitamin D, and has recently been started 3 weeks ago on tramadol for pain and pantoprazole. So as an aside, when she presented to Tata Hospital, we didn't see her. So this was the case history that I took from our electronic medical records. So she presented to the thoracic disease management group with a 3-week history of chest pain, cough, vomiting and diarrhea. She was noted to have localized lung mass, so a 3.5 centimeter right midlobe lung mass, and some few mediastinal nodes, but they didn't really uptake on the PET. So there was a concern, there was a discussion in the multidisciplinary team, and we thought that they were not involved nodes, so just a lung mass. And there was some uptake in the left iliac fossa in the cecum, which she underwent a colonoscopy, and that was not disease. So ultimately, she was diagnosed with localized lung cancer. She was discussed in the multidisciplinary tumor board. She was noted at that point to have a very good general condition. Her ECOG was 1, exercise tolerance was 2 floors, a 6-minute walk test was good. Her renal function was a bit elevated at 1.3 milligrams creatinine. And so she was felt to be fit. At that point, she underwent an upfront VATS lobectomy and selective mediastinal lymph node dissection. So questions for the panelists. So this patient was not referred to us prior to her surgery. Did she require a geriatric assessment prior to surgery? And in your setups, are patients being seen? So I think this feeds back to Dr. Sapna's question as well. So in radiation oncology and surgical oncology, are patients being referred for geriatric assessments? Do they benefit? I'll ask Dr. Kaneswaran first and then the other panelists.
Thank you, Vanita. And really interesting case, a survivor of colon cancer and then now with this new lesion. To answer your first question, does this patient require a geriatric assessment? The answer is yes. Prior to surgery, definitely the patient will benefit from a geriatric assessment. Now, the second part of your question was, is that routinely done globally? And that is variable. I think many surgeons, they may not call it geriatric assessment, but have prehabilitation programs. This means they actually work with their rehab medicine specialists, physiotherapists and all to assess these patients and start on some kind of preparation for the surgery in terms of physical therapy to get them fit enough. And obviously outcomes from this process would be a lot better in terms of recovery, in terms of hospital stay, shorter durations, things like that. So that's my answer to both your questions. In my practice, the surgeons don't necessarily do a geriatric assessment, but they do have such prehab programs in both hospitals here.
Dr. Soto, in your setup?
Yeah. In our setting, these patients will have probably be seen by what we do is that all patients age 65 and older now at our hospital are with a new diagnosis of cancer, at least undergo a GA, an SPPV or timed up and go, and a minico. And we train the oncology fellows and also some of the surgeons in doing this. And the urologists also do this. And when they find any abnormality in this screening test, patients get referred. So I believe that this patient will have probably be seen by us. I think that this is feasible and something that we should try to do in low and middle income countries and in a resource limited setting, training surgical oncologists and medical oncologists in at least doing screening tests for patients. I think it's very feasible, can be done everywhere.
Perfect. Dr. Steer, so I think a follow-up question to that for you, Dr. Steer, and then Dr. Anant and Dr. Prem. So if we did a geriatric assessment prior to surgery, presumably the patient is scheduled for surgery within a few weeks. So, and we think that the geriatric assessment is, by intervening, you will improve outcomes. So do you really have sufficient time to improve outcomes? And do we have any data that it benefits in the surgical setting?
So this is thoracic surgery, is it not? From
yes.
Memory?
Yes.
Yes. Interesting here, our thoracic surgeons are 300 kilometres away. We are a regional centre and we don't have that service. So, but we interact with them as part of a multidisciplinary team, as if they were in the next room, like I'm could be in Mumbai at the moment. So we have, that's something the COVID pandemic has done. It's helped bring teams together. So our patient would be assessed for in a major capital city. We don't have the ability to capture the patients prior to surgery here in our local centre, but they get a rigorous assessment prior at the bit larger hospitals in Melbourne. And of course, the cognitive assessment for me is the one here. I don't want to find out that this patient has a delirium risk after at the time of the operation or afterwards. You want to know that prior. So that would be the one that I'd be more interested in, quite apart from her physical assessments and ability to cope with the rigors of the operation.
Perfect. Anant and then Prem.
So I think this patient would require a geriatric assessment. One thing is that a lot of the pre-anesthetic checkups that are done for older patients are actually quite extensive, and that takes care of a lot of things. They do a 6-minute walk test, they do pulmonary function tests, they do, look at physio. So a lot of it, even if it's not technically called a geriatric assessment, I think a lot of geriatric issues are taken care of, in the PAC. So, I think, and all these things would help. I don't know the time duration. for these interventions to actually help the patient? Is it 2 weeks, 4 weeks, 6 weeks? Maybe someone else could throw light on that. And we know that majority of our patients, you would know that well also, Dr. Vanita, that the surgeons don't refer as many prior to a surgery, but the PAC takes care of a lot of things.
Prem, to you. So, are you seeing? So, Dr. Prem is a geriatrician practicing in a private hospital in Mumbai. So, are patients referred to you prior to surgery?
I think what Dr. Anand said, most of the times it is usually the PAC, which is obviously very standard that they do. But I think the PAC does not cover a lot of things. It covers more what the surgeon wants, to be very frank, and not necessarily what an older person who is having a surgery would want. So, for example, I had my own patient who had a thymoma. It was a thymic carcinoma. So, and the surgery went up. So I myself, because I was a geriatrician, so I did all the CGA and I sort of had it ready. Because I wanted to know what the outcomes would be. And I totally agree with Dr. Steer. I think delirium is something which is very standard. And sometimes, depending on the duration of surgery, whether it's acute or whether it's sort of a planned one, we tend to sort of neglect it purely because the focus is more on the surgical outcomes rather than the fact that the person can easily go into delirium. I have seen patients going into delirium after going into an MRI machine as well. an older adult. So another part, of course, very important in the assessment part, I think, is knowing the cognitive part in what level. For example, is it minimal cognitive impairment? Is it MCI? Is it even pertaining towards maybe even worse dementia? The reason I'm saying it should not always be the call that because the person has an advanced dementia, we should not do the surgery. But at the same time, sometimes if the comorbidities and everything is taken into consideration, then we might have to take an overall call when to do it. And as far as the weeks, the duration before, I would say at least once. See, this is where, if you remember, in case of palliative care doesn't start later. So at the same time, I would say that as soon as the diagnosis is obviously over and the decision has been clinically taken, the geriatrician or the geriatric assessment should be done baseline, and then even before surgery, just to know if something has sort of changed, which might make a major difference depending upon when the surgery is. Post-surgical, because surgery is done, but if the outcomes are not as expected, as far as a geriatrician for me is concerned, which includes quality of life, which includes whether the person will go into delirium, what is the physical ability that the person is going to have after the surgery. So these things, I think, matter a lot. And I think better sensitization and education is something, even for, as we said, medical oncologists to a great extent have really sort of world over adapted that geriatric assessment is sort of really needed. But it needs to extend to the radiation therapists, radiation oncology as well as surgical oncology. And purely, I think, in the level of tumor boards, which actually happens very commonly. I think at that particular time, if a geriatrician is involved or the assessment is already mentioned, then we are able to know the planning might actually go better. So I think that is the best way to go for.
No, I totally agree. I think our tumor boards, you barely maybe take a few minutes per patient, and I think the bottom line is that they have to be referred prior to for that. I'd like to keep this open and interactive. So if anyone has any questions, please ask at any point, and even if you don't, please ask. So moving on. Sorry, it seems to be stuck. Okay, sorry. So the patient underwent a lobectomy and a mediastinal lymph node dissection. Post-operative course was uneventful. She was discharged on post-operative day 4. Her histopathology showed a 3.3 centimeter adenocarcinoma. Margins were negative, but 4 mediastinal lymph nodes were positive. She was then referred to our medical oncology clinic for consideration of adjuvant therapy because she had a T2N2 lesion. So the first step was the medical oncology opinion. So the impression was an elderly lady with a history of CA colon, now with a second primary adenocarcinoma of the lung, PT2N2M0, but creatinine of 1.6. Her hemoglobin, now this is the post-operative setting, so it was 7.9. She subsequently got a transfusion. Her echo was normal. So the initial impression and plan was tentatively planned for adjuvant pemetrexed and cisplatin, followed by consideration for adjuvant radiotherapy. But consider a geriatric assessment. So she then came to see us in the Geriatric Oncology clinic. So, couple of questions before we go to her full geriatric assessment. Now, this is a patient who is quite old, and at the point that she was seen in the clinic, she was considered frail. But my question is this, and again, this does not happen for all patients. Many patients, a decision is made without a full geriatric assessment. So, I think this was covered in some of the talks, but if one of you could just summarize. So if a full geriatric assessment is not possible, what minimum assessment should be done other than a G8 screening test? Dr. Kaneswaran?
That's a good question, Vanita, and I think I alluded to this earlier as well. For a start, a screening like a G8, as you mentioned, does play a role, although while saying that, it adds a little information but doesn't really give you the full picture. So if really time is of essence and it's very hard to get a full assessment, other tools like the CARC toxicity, chemotoxicity score, especially if you're planning chemotherapy for these patients, is useful as well because it gives you an idea of what kind of toxicities the patient may experience, the grade 3 to 5 risk, and that can help you with regards to planning doses and also counseling patient with what kind of toxic side effects they can expect. So I think these things are useful, but may not replace what a geriatric assessment may provide in terms of the depth of knowledge that can help you plan. But I fully understand. Even in my practice, it's very, very challenging to do a full geriatric assessment for everyone. So you have to make do with what you can do, and it's practical for use in your own setup.
Perfect. And I think I'll ask Enrique to summarize, because Enrique practices is perhaps the most similar setting to us in Mumbai. So in your setup, Enrique, G8 CARG ideal? What is the bare minimum that is done?
So our setting, the bare minimum is doing a G8, a mini curve, and some functional tests like time of go. However, I do believe that even in limited resource settings, doing a geriatric assessment that contains more of the things that the ASCO guidelines recommend is feasible. So at least assessing IADL, a quick screening for depression. I mean, you can use PHQ-2, which is 2 questions, weight loss, very easy to do, assess or ask about falls. We've even developed a short self-administered geriatric assessment in Spanish that takes 15 minutes for the patients to complete on their own. So I do believe that the core things that ASCO guidelines recommend should be done in patients like this that are starting a new treatment, a long treatment, a complex treatment. So I think that for these patients in particular, there are ways to do a more complete geriatric assessment, and I wouldn't be happy just doing screening for a patient that's gonna undergo adjuvant chemotherapy and perhaps radiation for lung cancer. And again, we have to get rid of the idea that doing a more complete geriatric assessment is very time consuming. We can actually look at the important issues without taking a long time.
I have a question here, Dr. Vanita, if I may.
Please go ahead.
Yeah. So while I was looking through all the instruments that we were going to, possibly use in our setup, I came across this numerical multi-dimensional prognostic indicator. And I just wondered if somebody had any experience of using it, because it seemed to really be very thorough and, give a numerical value to everything. So I just wondered if there was any experience of using that.
What tool is that?
Well,
Dr. Nanjia?
multi-dimensional prognostic indicator, I think it comes from some Italian groups, and there seems to have been some work in Europe on using that tool to, do decision making.
I think it's something similar to the Onco MPI. So it's essentially, if I'm not mistaken, it is a complete geriatric assessment, but with points that have been given to each vulnerability and each domain. Is that correct, Dr. Sapna?
Yes, very right. So this is, I think this predates the Onco MPI and just is MPI. And so I just wondered, has anyone used this? And Onco MPI too? Do you use that, or is it just G8 and the other one, the chemotherapy? Because the chemotherapy tool is, doesn't really help, for example, a radiation oncologist or a surgeon.
So I'll ask Anant to talk about that. We were, I agree, we were also quite excited because, this, the geriatric assessment is so subjective, and we really, at least, have not really been able to come up with a very objective way to decide what to do per patient. So the idea of having a numeric scale and, giving a number and whatever the number is, you decide based on that was quite attractive to us. So Anant had done some work looking at our data. So Anant, you want to discuss that?
I think what Madam Dr. Sapna is referring to was the initial 2011 when, the MPI came about, and then I think the Italians came up with an Onco MPI in 2016. I think that's the chronology. The thing is, it's not an easy equation to apply. This is when we were analyzing our own patients, we decided that we'll analyze a little later because some of our patients had a shorter follow-up. It's actually a very long logarithmic equation. But that said, if you had an Onco MPI calculator, it predicts very well. It clearly differentiated. I think they had cutoffs of 0.45, 0.65, things like that. And those who had a score of 0.45, there was difference in terms of survival in years, not just months or something. So on paper it looks great, but you need to have that calculator. You cannot manually enter those values because that would take a long time in itself. We tried to validate it, but we now decided to wait a little longer for follow-up because the follow-up in our patients was much lower. They had a good follow-up of more than a year. So maybe we'll have something in the Indian setup maybe in 6 months' time or so. But it's a long equation. I think you should see the equation to know how long it is.
So maybe I can add something here. But here, with Onco MPI, it's a prognostic tool. Am I right? It gives you prognosis. So, a decade ago, we did something similar and published it at about the same time as when CARG and CRASH was coming out as well. It was a nomogram, and it was a prognostic tool as well. And it used, and we used, at the end, after our analysis, we found that there were 6 factors from the GA that were relevant. And then on the nomogram, you can plot and see what their 1, 2, and 3 year mortality is going to be. Now, the challenges with all these prognostic tools, just like e-prognosis, is that it doesn't really tell you what you should do with your patient. How should you treat your patient? Should you dose reduce? It tells you what to tell the patient about their prognosis based on multi-parametric assessments. So, like Christopher had mentioned in the chat box as well, e-prognosis was developed mainly in Caucasian populations. So whatever information you are going to get from your studies in India and in Asia would be useful to see whether there are differences in our own populations, and I suspect there will be. So I think for tools like this, if it's not been validated in an Asian or local setting, then I would say be cautious when using them. And again, you need to also think about applicability, because even with CARG, firstly, it doesn't. There were multiple tumors in there. There are limitations to the usage of CARG. How would you counsel a patient when the CARG score comes out as 50%? What are you going to tell the patient? There's 50% risk of getting grade 3 to 5 toxicity. But how does that translate to what is going to happen to me? So that's what the patient will want to ask you. So you need to have answers to all those things, you see. So whenever you come up, you want to use any of these tools, you have to take it in the perspective of what is the next step and have a plan for that as well that's useful and relevant to the patient. Otherwise, you'll be stuck.
I totally agree. So, moving on, so the patient came to our clinic, and these are the results of the geriatric assessment. So, before we go through all of these results, Dr. Steer and then Dr. Prem, is it valid to be doing a geriatric assessment in the post-operative setting, and how do you interpret those results?
Thanks for the question. Just to continue on the previous ones, I'm approaching this as a medical oncologist with the patient coming to me in whatever time, and I'm going to want to know how can I enhance their supportive care with a cancer in the older adult lens, and I need to know more about them. The screening tool that we use is the G8, and then Armin Sharokni's ERFA, 15 minutes. You do the tug and the mini cog. And then that's so we don't have a geriatrician to lean on constantly. And so I'm a medical oncologist. I've got resource limitations. We've got an electronic thing. And I want to know that as early as I can. But of course, they need to be stable. So they can't be unstable after the post-op period, clearly. But if they're stable and considering adjuvant treatment, I want to know their prognosis without the cancer, hence my question about the prognosis. And then this is a framework to build the supportive care that's needed to get them through adjuvant treatment, significant adjuvant treatment, if their survival is good enough and they agree. That would be my approach.
Perfect. Dr. Prem? So I guess my question is, do you adjust what you find in the geriatric assessment after an acute event? So sometimes a patient falls the previous day and comes to us and you can't assess function, and we'll talk about that in a little bit. But do you have to put some sort of an adjustment to it?
Actually, for example, if somebody has had an acute event in which there is a significant depression of function, we know that the baseline has gone down. But if you're saying that we do the entire thing there, then we might not get the results that we actually want. For example, a very simple way, if somebody has fallen and the person is in pain, for an older adult, pain can induce delirium, pain can induce results for whatever we ask. And maybe it's a lack of interest, or maybe it's just they don't want to answer. So that can be a big sort of back as far as the results of the geriatric assessment are concerned. So we would not get what might be the actual sort of result. So I think we might have to set, I wouldn't say that there is a fixed amount of time in which we should wait, but all I can say is if we feel that with basic thing, for example, if the mental status that we feel is okay, which could be purely GCS, or we ask leading questions for the memory and of course for pain, and then we will be able to know at least the answers that we are getting, they are right or not. That is one. And another thing, because Dr. Joeta is not with us, there is of course her screening tool which she would have talked more about.
Scope-C.
Scope-C, that is screening for older cancer, screening of older cancer patients. So that is basically, I myself have sort of done it for patients as well. So it doesn't take a lot of time, but again, it sort of needs validation, which we obviously know because multiple centers in India need to do it, and then we need to it has been done in AIMS in New Delhi. So I think that is also another scale which we should look at least in the Indian setting, because it has been done in India, and maybe that is something which we sort of can, sort of apply to various centers and get some data and know where exactly it sort of helps us in better treatment as far as older adults are concerned with cancer.
Perfect, thanks. So we'll go through each of these relatively quickly. I think we are almost out of time, but in terms of assessment of function and falls, Dr. Sarika, can you comment? And any tips for us how we can implement that in the clinic?
So ma'am, if we are looking at the patient's history, the ECOG score is 2 and patient already has a history of fall once. So we need to go ahead and do detailed assessments for balance and also for strength. So we usually use the SPPV model, which is very, very safe and most of the patients can perform. And if you look at the TUG score also, it's more than 12. So for such patients, what we need to do is, we need to do an individualized intervention. So like we were discussing before, as to how much time is enough for interventions. from physical therapy point of view. So there are many papers which quote saying that, you can go at least for minimum of 2 weeks of interventions, working on the strength, balance, and improving the aerobic capacity. So I think if we can work on these domains for at least 2 weeks, the patient can sustain for the next 6 months to a year and cope up with the treatment which she's will be going.
Perfect. Thanks, Harika. And I think that's an important point. We try to send all our patients to you. Now, this is the actual geriatric assessment. So you notice that there's no SPPB as part of this because this patient didn't actually reach you, Sarika. So I'll ask Jyoti to comment on this. So how much of difficulty do you find in terms of patients following through with what we recommend, and as well as in terms of filling out the patient-related forms? And
most
tips for us
often
for
like
that.
it's like when the patient comes, the patient is always in a hurry to to get his chemotherapy or radiation. So it's explaining the importance of having the geriatric assessment is like the first point of contact for me. And it's most often the caregiver who comes. So explaining the importance is that's what I start with, and then when the assessment is done, the referrals for psychotherapy or for physiotherapy. So again, I have to, because generally the patient has to go to so many places and they are in the mode of can I just skip this? So I kind of if you want to remain active, and the importance of the exercise, that is what I tell them, and then later on I keep following with them after 2 days or so, because if you keep calling them, the probability of them going and visiting Sarika ma'am is that's higher.
Thank you, Jyoti.
So
Real world problems, I guess. I don't know, in other setups, do you have a sense as to whether patients are actually following through on interventions and recommendations, I guess, rather than interventions? Enrique, Dr. Steer, Ravi?
Actually, in Singapore, the issue is also cost. Because with every intervention, the patient has to pay an additional cost, and there's convenience factor because they need if it's not housed under one roof within the same setup, they need to go to another center for physiotherapy and another clinic somewhere else. And even if it's within the same campus, all these distances for an older adult can be challenging. So what I find is, ideally, and we are moving to a new cancer center with more space, I may be able to overcome some of these issues by making it a one-stop shop. That means either within the same floor and also have to try to find a way to bundle the cost. Because, ultimately, if you are not getting support from philanthropy or the government, patients have to pay for the nutritional advice, the physiotherapy, the occupational therapy, any form of additional support, seeing a geriatrician, all this is going to cost money. And for many patients in Asia, where a lot of it's out of pocket, they'll think twice, even if you convince them it's essential. So that's why you need to build some form of multidisciplinary team and bundle these packages such that you can bring down cost and make it worth the patient's time and effort to get these things. I feel those are the big hurdles that I'm facing as well.
Perfect. And I think similar here. Enrique or Dr. Steer, anything to add to that?
No, I agree with Ravi. There is a need to integrate this into a single visit. We've managed to have a nutritionist and a physiotherapist at the same geriatric oncology clinic, and that helps us implement some interventions. And I think another very important thing is to adapt our schedule to the patient. So many of the patients will be coming to the cancer center a lot for chemotherapy, radiotherapy, etc. So there are a lot of opportunities for implementing interventions in these idle time patients have. So while patients are waiting for chemotherapy, or even while they're getting their chemotherapy, there are opportunities for educational interventions, etc. So I think that those are things that could be optimized to provide this care. We've had good results at follow-up and at the acceptance of regarding interventions, as long as they see it as part of their usual care. No? So I do think that we need to integrate this. This is part of your cancer care. It's not an extra thing. It's part of the team.
That's right, Enrique, and I think you should get the award for the, since it's 1:15 in the morning in Mexico City, so welcome to my world, but you've done superbly well. And yes, as someone who I have the privilege of sitting on the CARG clinical implementation group where we hear the experiences of people who are trying to integrate geriatric assessment and services into their cancer centres around the United States, England, the Royal Marsden is doing a fantastic job at the moment, Australia. And everyone has similar problems, but with those problems come opportunities. And so use the things that you've got. I know you're doing superbly well in your Indian centres. Use your teams, do what you can, and try and get if I can do it on a supportive care lens like we're doing here, you get the information early and support the patient through their journey. And that's what I'm learning. Use your what you've got wisely with the patient at the centre, and you can't go wrong. And look, you're doing it amazingly, Tara Mumbai. This is a fantastic event, and I really appreciate the opportunity to be part of it. Thank you.
Thank you so much. Sridhar, your comments on nutrition assessment. So this patient was actually okay nutritionally, but her MNA was 24, so still vulnerable. So she's in the post-op setting. She's not really eating 3 meals a day. Your comments on sarcopenia or nutrition? Or?
Yeah, so thank you, ma'am. So of course, we are also using the MNA in routinely in clinical practice. Now, there are some modifications of the MNA. Sometimes you cannot go by the BMI for a lot of patients, especially these older patients who might have a high BMI but will be frail. So a frailty assessment and some modifications of the MNA, like the proportional MNA, may be of use in these settings. So a formal frailty assessment is something that I guess we miss out on commonly in these older individuals, and so I guess that also has become part of an assessment at our nutrition clinic now. I think there was discussion on, because of the pandemic, a lot of patients starting to use telemedicine. So for nutritional assessment, again, recently there have been papers on self-MNA. So off late, even for phone, for teleconsults, we started using some self-MNA. So again, that has come in, and that's already validated. So it's been of good use for the nutrition clinic, and at least it gives us some sense of assessment as to how the patient is nutritionally. So overall, I think it should be a combination of both an objective scale like the MNA and some frailty assessment when the patient actually comes to the clinic. Another issue becomes these patients, their intakes are low. Especially the ones who are extremely, low BMI, they have a very high risk of refeeding once you start, nutritionally rehabilitating them. So again, that becomes a major concern. Of course, not in this patient. She seems otherwise okay. But in those patients who are really below BMI, that becomes a concern. So all of these are, common issues that we face in the clinic.
Perfect. In the interest of time, I'll just take just one more on for Vikram. So your comments on the medications, and I have to admit that she actually was not on all of these medicines, so I added a couple of them because these are the ones that we see are most commonly prescribed to almost all of our patients. So just your comments, Vikram, on polypharmacy and these medications that the patient is taking.
Okay, as you see, the prescription has all the bad boys of polypharmacy of geriatric oncology. So if we have to go one after the other. So hydrochlorothiazide, there are a lot of good studies in the past which have shown that hydrochlorothiazide is very effective in preventing cardiovascular events, especially in elderly patients with mild hypertension. So, but once again, the effectiveness is only at lower doses, and then the higher doses are likely to have complications. So predominantly dyslipidemia, gout, and so on. So in this case, a patient with already creatinine of 1.6, I don't know if I want to risk treating with hydrochlorothiazide. Perhaps if I have to, I'll stick with a low dose. Otherwise, there are definitely comparable drugs with comparable activity, but lesser toxicities. Maybe ACE inhibitors or ARB may be a good substitute, or even a calcium channel blocker. So that's how I would look at it. But if it is mild hypertension, hydrochlorothiazide is not a bad drug, but definitely we can consider alternatives. When it comes to glimepiride, yeah, I mean, in the sense, some of these long-acting sulfonylureas, one should be very, very careful in older patients, because the risk of hypoglycemia and then the subsequent complications, maybe chances of fall, because the patient already has had a history of fall once in the last 6 months. So definitely glimepiride is a no-no in this case. A better alternative would be gliclazide, because it is short-acting. It has a lower propensity to cause hypoglycemias. So maybe, I would want to consider, replacing glimepiride with gliclazide. Then tramadol. Tramadol, once again, in very old patients, beyond 75 years, especially with impaired renal function, because her creat is 1.6, so her creatinine clearance is likely to be in the early 30s or 40s. So once again, the elimination of tramadol will be affected. So they're likely to have more complications of tramadol, like constipation for that matter, or even SIADH is more likely at this age. And long-term tramadol treatment can cause problems like seizures and Alzheimer's and so on. So yeah, I mean, once again, in older patients, it has been shown that a low-dose tramadol is what we should start with if you have to. So a patient more beyond 75 years, I would start with a dose of 25 milligrams and then see how it goes, how the pain control is. And first of all, an assessment should include whether she will require tramadol at all, or we can manage with acetaminophen, because that is as good for mild to moderate pain. But if tramadol is absolutely indicated, then I would start with 25 milligrams and escalate from there on, but definitely not more than 300 milligrams a day.
Perfect, thank you. And lastly, the psychological status, Dr. Joyita Devdar, your comments on, if they do have depression or insomnia, your tips for us, and how do we help these patients through? And she has somewhat of a borderline cognition. So if we did plan her for chemotherapy, anything that we could do to help?
Thank you, Dr. Vanita. So I think the cognition, it is still sort of mild, and then she's had a history of surgery already, so I wouldn't really worry so much. I will do a cognitive testing as part of my mental state assessment. It's important the thing that is going to be making more significance is whether there has been a change. So if there has been a change from her pre-morbid functioning to now, I need to take care of that. For her, the other scales that you have used, so as part of that cognitive testing, we should talk about her decision-making capacity, and that is why the corroborative history from the accompanying person is really important, and somebody who knows the lady, not as somebody who is just accompanied on that day. That's an important consideration. For the GDS and the GAD, there doesn't seem to be anxiety screening as such on the screening, but the GDS is 5, which is mild. But for our assessment, these are screening tools. We would do our own assessment and do a thorough mental status examination, which would give us a diagnostic formulation. For tips, it's important to have that they really like to share their experiences and talk. And a lot of it, what they have gone through is medical. So that bit has been, during the part of the assessment, that kind of sort of informal discussion and sharing does help a lot, and we should always think about that loneliness and the isolation bit, and that we need to do that. We were talking a lot about follow-ups and whether they follow up when the appointments are made through, but because the appointments are made through well in advance and they have a specific time for that, we haven't had any difficulties in them attending our appointments. And for follow-up, I understand it's difficult again for them to come because they have so many things. We usually tell the family to please come and report to us either way, or else if they have been started on any antidepressants or any other medications.
Perfect, thank you. I think in the interest of time, I'll end. I had so many questions about how to decide her treatment, but we'll leave that for the next because I don't want to overstay our time. So I just wanted to acknowledge everybody on this slide has really helped me because I have no formal training in geriatric oncology, and I was totally lost when I decided to start out. So I reached out to each of these, and I have realized that the geriatric oncology community is really such a helpful and a collegial community. So whatever question I've asked has always been answered, so thank you. This was the lecture given by Professor Andrew Chapman, and when he had received the ASCO Award for Geriatric Oncology, and he had said that geriatric oncology is a team sport. So it totally is a team sport. So thank you to all the members of our geriatric oncology clinic at Tata. It's growing. It started as 2 people, and it's now, I don't know, like 15 or 20 people and growing. So thank you all very much. Akhil, the stage is yours for the quiz.
I have one last question.
Yes, please. Please go ahead.
Dr. Sundaram was mentioning about frailty. So it's assumed that most of the people, when they grow old, they become frail. And I just wanted to know if anyone could share some light on the use of Edmonton frailty scale, like how, if anyone has ever used that for assessment of frailty in older patients.
Dr. Steer or Enrique, Dr. Soto, would you like to take that? So I'll tell you from our experience in the clinic, so we are using the Rockwood frailty scale, which is scored by the physician. And I have realized that we are always very optimistic in terms of what we rate the patient, because I see that it goes from 0 to maybe I think 10 or 12, and 1, 2, 3 is very fit, and 12, the higher numbers are very frail, and invariably the patient is scored as frailty 3 or 2, and then I look at the ADL and the patient is not even able to do 3 ADLs. So I say, this is not possible. So I'm not really sure about the how valid it is, at least not in our setup, until we realize, we explore more with the patient. Comments from Dr. Soto, Dr. Steer, Dr. Kaneswaran, or Anant? Or?
Yeah, well, I think that the concept of frailty from the geriatric standpoint and the oncologic standpoint is not exactly the same. I think that some of the frailty definitions used in geriatric, like the Rockwood scale or even the frailty phenotype, are not necessarily validated in cancer. So even though this may make sense from a geriatric standpoint, it's not the same as the geriatric oncology frailty concept, no? Which is not exactly the same as that used in geriatric. So for some of the definitions of frailty in geriatric oncology, like the Balducci scale or other things by SIOP, are a little bit different. So there is no clear use of the frailty phenotype for cancer specifically. The Edmonton frailty scale is very nice because it encompasses a lot of things that we normally do in the geriatric assessment, like IADL, continence, etc. It's more of a definition of frailty based on the accumulation of deficits than on an actual phenotype. So I think that the definition of accumulation of deficits is much more compatible with what we usually do in geriatric oncology, rather than the phenotypical definition. I don't know what Christopher thinks about that.
It's a complex issue. Whilst medical oncologists and others like numbers, I think geriatric assessment is a way of personalising care in a way that my colleagues want to do next generation sequencing on the tumour. It's personalising in one way, but it's not the same as actually doing an adequate assessment and guiding your care of the patient, individualising that. And you can do frailty numbers to maybe help in decision making. I haven't seen any evidence that helps yet. There are many scales. And the other answer to that always is, well, if you feel useful using one, just pick one, because there certainly isn't any differences between them, and the Edmonton score may be helpful. But whatever you find comfortable, whatever your geriatricians are used to using, with the caveat that Enrique says that there is difference between older adults with and without cancer. I don't use a frailty scale, in preference to the simple assessment.
Perfect, thank you. I think we'll hand over to Akhil, because we are running a bit late.
Yeah. Thank you, ma'am. So now we will be conducting a short quiz. It will be a 5 questions based multiple choice questions, best of 4. And there are some questions which are based on the basics of geriatric oncology and 2 on the important recent trials. So technical team, please project the slides. There will be 30 seconds for each question actually. So starting with the first question, which of the following is not correct about the G8 screening tool? Score lies between 0 to 17. Higher score, better health status. Score more than 15 should undergo CGA. Includes age, food intake, weight loss, mobility, BMI, and neuropsychological problems. So quiz is for the students, not for the consultants. Please don't give answers on the chat box. I think the time should be up. Yeah, time is up now. Let's move to the second question. Which of the following is false about the CRG tool? This was discussed today significantly. This tool is based on data of 500 older patients receiving chemotherapy, and it was worked by Guriya et al. Poly versus monochemotherapy is included as a part of the risk assessment tool. Type of cancer is also a part of the tool. Administration time is around 20 minutes. So it is about false about the tool. We need to select the best answer out of the 4. So time is up. Let's move to the next question. So which is true about CRG versus CRASH tool? So these are the 2 basic tools used for assessment of chemotherapy toxicities. CRG tool is validated for patients over age 70 plus. CRASH tool's administration time is shorter. CRASH tool is validated for patients aged 65 or more. CRASH includes IADL, MMSE, MNA. So which is the following is true? Only one out of these is true. Select this. Okay, let's move to the question 4. So which is of the following is not correct about the GO2 trial. So this was a recent trial and this is very important for us now. It was a phase 3 trial in older patients with gastroesophageal cancer. 3 dose level of capox were used, 80, 100, 80 and 60% doses. Both PFS and OS were found to be similar in all the 3 dose levels. Reduced doses did not lead to any difference in the quality of life. Which of the following is not correct about the same? Select the best answer.
Advanced.
So let's move now to the final question. Which of the following is correct about the GAP 70 plus study? This was also discussed today. Geriatric assessment led to improved survival in patients with age of 70 plus years. Grade 1 to 2 toxicities were significantly reduced by following geriatric assessment. Grade 3 to 5 toxicities were significantly reduced by using geriatric assessment. Significantly higher number of patients in geriatric assessment group were offered more aggressive chemotherapy. So you need to select the correct out of the 4. So time is up. The results will be announced separately, and the top 3, those who come in the top 3 will be given free registration to the next ESMO Asia conference. That was announced by Vanita ma'am. Thank you. We can stop now. Back to ma'am for final comments and closing session.
Sorry, so we are, thank you, Akhil. And I think we had forgotten to announce the prizes for the quiz. So the top 3 will get free registration for ESMO Asia 2022. So we should have announced this before so more people participated, but either way. So thank you so much. This was really, it's always an eye-opener to me to hear what other people think and how people practice. So thank you so much. I hope that all of us can go back and at least assess a few more patients appropriately in our clinic. So thank you. Thank you all.